being recorded. This is a lunch and learn and is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health providers with any questions you may have regarding a medical condition. We ask that everyone stay muted during the event and submit your questions through the Q&A box. Please do not send any private questions to Dr. Eisenberg. If you would like to submit an anonymous question, please send it to me directly as a private message, or you're welcome to post a question so that everyone can see. This series was produced in partnership with the Swedish Medical Center Foundation. Philanthropic investment from our community is what allows us to offer the innovative, patient-centered healthcare available at the Center for Healthy Aging. To learn more, please visit www.swedishfoundation.org. And now I would like to introduce Dr. Nancy Eisenberg. Dr. Eisenberg is the medical director of the Center for Healthy Aging at Swedish Neuroscience Institute and Providence Health and Services, and co-leads Project ECHO Dementia. She is a subspecialty trained behavioral neurologist and neuropsychiatrist with expertise in implementation science, clinical neurodegenerative disease, and functional brain imaging. She has 25 years of experience in medical care for persons with Alzheimer's disease and related disorders and their families. We'll begin with an approximately 20-minute presentation from Dr. Eisenberg, followed by about 30 minutes of Q&A, and close around 1 p.m. With that, I will turn it over to Dr. Eisenberg shortly.
Thank you very much for that kind introduction, and I'm delighted to be here with all of you. Just a thumbs up if you can hear me well. Yes, can everybody hear me? Okay, good. All right. So thank you, Marnie, and thank you, Erica and the foundation. And this is, as was said, the first of our 3 series, Lunch and Learns. And I'm talking to you today about research. And I literally this morning came from a Dementia Action Collaborative meeting where we were fortunate enough to also speak with a colleague who summarized some of the science that I'm going to present to you today. So this is really up to date. Okay. So in 2020, over 5 million Americans are presently living with Alzheimer's disease. And the risk accrues with advancing age. So the single greatest risk factor for Alzheimer's disease and other related dementias is advanced age. And as you see, if you're fortunate to be an octogenarian, your risk is greater than 30%. So for starters, we'll jump right in, and the Alzheimer's Association International Convention is the largest conference, that presents the most up-to-date research on dementia. And this was intended to convene in Holland. However, as you can imagine, with COVID, the pandemic, this was a virtual conference. And the opportunity with the virtual conference was it allowed for people from over 160 countries and many more to really participate and engage and to disseminate this critical information throughout the globe. And so while we are all confronting challenges with this pandemic, I also want to highlight some opportunities, and particularly as regards engaging with information. I do think that this virtual space that we are all here together in today is here to stay. So as many of you may be aware, COVID-19 disproportionately affects individuals with Alzheimer's disease and dementia, and almost half of the COVID-related deaths are in long-term care facilities. And so we have been called, we meaning stakeholders who are working with individuals and families with dementia through the Dementia Action Collaborative, to really be nimble around implementing systems for safety and isolation, which does not worsen that social isolation, but yet does offer the physical protection of a mask or distancing and so forth. So this was one of the updates. Another update is that the COVID-19 infection in and of itself increases the risk for dementia. And as many of you know, this disease affects the lungs and can affect oxygenation and blood flow to the brain, and also can cause an inflammatory cascade as well. And people are at greater risk for strokes and dementia in the context of a COVID-19 infection. Additionally, as we're all feeling that sense of physical isolation and loneliness, these can be really lethal and can increase our risk for dementia as well. And then I'll add, thirdly, people who are needing medical attention have been frightened to go to the ER. So, for example, if somebody is having a treatable TIA or stroke, which maybe would respond to a clot buster, we have seen people avoiding the emergency departments, looking at what we would comparing last year's visits for stroke in the ED compared to this year's visits. The third update from the Alzheimer's Association International Conference has to do with getting your flu shot. So I'm going to really encourage all of you, if you haven't yet, to make that appointment with your primary care team to get the flu shot and the Pneumovax, because both of those vaccinations are associated with a reduced risk for Alzheimer's disease. Now, we don't understand the relationship because it was an association study. So it's possible that people who have their flu and pneumonia, Pneumovax, annually have better access to healthcare or have overall better health. It also may be that it's helping them to avoid hospitalizations. And I really strongly encourage everyone here to speak to your primary care team about a flu and Pneumovax shot if you have not already. Okay. The fourth update, really underscores that it's never too early or too late. This focuses on it's never too early, and I will be talking later about how it's never too late, but really it's never too early to target modifiable risk. And so this was a study among adolescents and young adults who have elevated BMIs or obesity, have hypertension, diabetes, and poor levels of education. And these four factors, measurable in adolescence and young adulthood, are associated with increased dementia risk. Again, really highlighting the importance of a lifespan approach to targeting modifiable risk at the population health level to impact the incidence of dementia. And when I speak about dementia, the most common cause is Alzheimer's disease. And a second cause and contributing factor is vascular disease and metabolic disease, and these interact as well. So the fifth update has to do with a blood test, which people might have seen in the press. So soon is probably 2 years still down the pike, but nonetheless, it's very exciting to think that, and I have a slide for this later in the presentation, that there may be a blood test which is affordable and not invasive in the way that some of the other biomarker detection studies are and currently. So this is looking at a protein, phosphorylated tau 217, which in the blood is associated with Alzheimer's disease. And lastly, and I think we've known this in the dementia medical field for some time, but just raising the awareness that psychotic symptoms are very, very common, and in particular, hallucinations and perceptual distortions are common in dementia-related psychosis. Okay, so I want to highlight for you all the disparities and prevalence. As I said earlier, the single greatest risk factor for dementia and Alzheimer's disease is advanced age. And African Americans are twice as likely than non-Hispanic white Americans to have Alzheimer's and other related dementias. And as part of the work for the Dementia Action Collaborative, we have pamphlets and information to distribute more widely to raise this visibility and to destigmatize this in communities. Hispanics are about 1 to 1.5 times more likely than whites to have Alzheimer's and other related dementias. And African Americans and Hispanics are typically diagnosed in the later stages of disease. And whereas almost 2/3 of older Americans with Alzheimer's disease and dementia are women who tend to live longer. So what does the typical progression of Alzheimer's disease look like? Well, we know that Alzheimer's disease, the neuropathological burden, the plaque entangle, the protein aggregation in the brain precedes that clinical presentation by decades. So there is a pre-symptomatic phase, a prodromal phase, and then dementia, which is defined as loss of cognitive function in 2 or more domains that really impacts your overall functioning. So this can be 30 years, many decades. And in the prodromal phase, we have a term called mild cognitive impairment. And what we mean by that is individuals may have some memory loss or some cognitive challenges, but it doesn't really impact overall functioning in day to day. So when we want to think about targeting treatments, we want to really be able to change the accumulation of that neuropathological burden over time, and consequently to prolong that pre-symptomatic phase so people can have a longer health span or live well with mild cognitive impairment or their dementia. Okay, so this was the headline in the New York Times. Amazing, isn't it? Long sought blood test for Alzheimer's in reach. And whereas some of you may have seen this is a positron emission tomography or a PET scan, which demonstrates typical hypometabolism in the temporoparietal region, which is a biomarker indication of the neuropathological burden for Alzheimer's disease. It's one of the ways that we detect Alzheimer's disease currently. This is a costly test. It's an invasive test with radiation, and a blood test, as I said earlier, would be affordable, widely accessible, and not invasive. And this was the original article that came out in JAMA. And as I said, I do think that we are still a ways off, but in this preliminary study, they were comparing the biomarker, this plasma phosphorylated tau 217, to people who'd had PET scans, and there was a very good correlation. So it's a smaller sample, it needs to be extended, but it's, I think, very exciting. And you know, perhaps in a year or so, we'll have more studies to present on this. and then to distribute. Okay. So these are the Alzheimer's disease facts and figures, and it's the sixth leading cause of death in the United States. And 1 in 3 seniors dies with Alzheimer's disease or another related dementia, mixed dementia, vascular dementia, Lewy body dementia. And it really affects and it kills more people than breast cancer and prostate cancer combined. I really want to acknowledge also the um, contribution of over 16 million Americans who are providing this unpaid and really essential care for people who are living with Alzheimer's disease and other dementias. And also for us to consider that at this moment in time with this pandemic, we have families who are sandwiched with caring for their beloved parent and also helping teach their children with homeschooling through virtual schooling and trying to work. So this is really very challenging at this moment. Half of primary care physicians feel that the medical profession at large is not ready to provide the necessary care given the incidence of dementia and that we're all living longer. The good news about that is that over the past decade in America and in Europe, the incidence of Alzheimer's disease has actually decreased. And we attribute this to better care for stroke prevention, modifiable risk factors, which I'll speak to in a moment. So over 80% of primary care physicians are really on the front lines of providing this dementia care. And I'll present in an additional slide a project that I'm co-leading to improve the care and to support our colleagues to really provide the best care possible in the right place at the right time for this need. So people who have Alzheimer's disease, only about half are actually diagnosed. And of those who are diagnosed, only 45% of them or their caregivers are actually aware of this diagnosis. And among those who have the disease, only a third are aware of the diagnosis. So we really need to improve early detection and patient-centered education so people can access programs and services and target risk. So this is a commission dementia prevention, intervention, and care study that came out now 3 years ago. And it identified 9 factors which can reduce the risk by a third. So those early factors are ApoE4, which we'll speak about, poor education, hearing loss, hypertension, and obesity, smoking, depression, physical inactivity, social isolation, which I spoke to earlier, and diabetes. And just recently, the Lancet Commission convened again, and this is a meta-analysis. So they are looking at data from many, many studies globally. And they have identified 3 additional risk factors, so 12 risk factors. And by targeting those 12 modifiable risk factors, 40% of population attributable risk is reduced. So 40% of dementia cases are preventable over a lifespan by targeting these risks. So we spoke to education, hearing loss. Traumatic brain injury is a newly identified modifiable risk in midlife. So really avoiding repeated concussions. Most of us have had a concussion playing sports, but what we're talking about in terms of traumatic brain injury is not mild traumatic brain injury, but more moderate, multiple concussions with sequela. Alcohol also was identified as a risk, a modifiable risk factor in the current Lancet Commission review. And for folks who had greater than 21 units per week. And then we also saw obesity previously in midlife. And then air pollution is the third of the new modifiable risk factors. And as I said, this really accounts for 40% of modifiable risk, which I think is very encouraging. Okay, so as I mentioned, I have been fortunate to spearhead efforts that are supported through the state to improve dementia care where it's needed, which is on the front lines in primary care. So really, how do we provide the care where it's needed, moving knowledge, not people or providers? And this is a hub and spoke model. In the hub, I co-lead this effort with other experts. It's an all teach, all learn model. And there's a case-based learning and a didactic, a focused 15-minute brief presentation, and then we review evidence-based programs and services and best practices. So as I said, it's an interdisciplinary hub model. I am the cognitive neurologist who is co-lead. And we launched on the 12th of June in the midst of this pandemic. There are CME and CNE, which are accreditations through our medical and nursing education boards. And we have over 25 sites throughout the state, and we're growing. So I want to talk for a moment about mild cognitive impairment and perioperative delirium. So as I said earlier, mild cognitive impairment is that prodrome where somebody has some memory loss, some cognitive issues, but they're doing pretty well functioning independently. So we know that dementia has an increased risk for perioperative, postoperative delirium, but I want to point to here is the association of mild cognitive impairment and delirium. And we also know that delirium is associated with a risk of cognitive decline following surgery. And the reason that I really think this is important to raise awareness today is that, you know, if you're considering an elective surgery over the age of 60, I think that you ought to have a very focused conversation with your team about not only the cardiopulmonary clearance, but also what are the cognitive risks, and might there be other approaches to target that challenge, whether it's pain in the knee, for example, you know, where physical therapy and other approaches may be effective. I'm talking specifically here about elective surgeries. Of course, some people need to have emergency surgeries. But people with mild cognitive impairment have an increased risk for this perioperative delirium, and that delirium in and of itself is associated with an increased risk for dementia. So the Center for Healthy Aging, our center at Swedish Neurosciences Institute, is really committed to providing evidence-based, patient and family-centered healthcare through intraprofessional, team-based prevention, detection, and collaborative care strategies, and through developing partnerships in primary care, through the research implementation science to deploy these education and screening tools more broadly, and through really developing a cognitive care pathway through the continuum from the community ambulatory context right through into the ER and the hospital. And we have ongoing partnerships that are developing there as well. So I want to also just take a moment here to really acknowledge that much of what we do and much of what we are building and what we aspire to do in the Center for Healthy Aging relies on this philanthropic support. So in addition to this multidisciplinary medical care that we provide, many of these programs that we are offering as part of our comprehensive care are value-added patient services. And philanthropy allows us to offer these things like caregiver support programs or population health educational events and other supportive services that fall outside of a regular clinic visit and therefore can't be billed to insurance. It also really allows us to do these things that we're talking about, like research. And this research really does further our understanding and consequently can improve quality of life, health span, and time for people living well with dementia, the time that they have with their loved ones. So we're not fundraising to keep the doors open or for the medical care we provide. We're really partnering with our community so that we can create a premier comprehensive destination for the prevention, care, and treatment of dementia. So I really encourage you to visit the Swedish Foundation website to learn more about how you can support a Swedish Center for Healthy Aging. And I'm happy to take any questions. Thank you so much. I think I'll stop screen sharing and I'll look at the chat. And I want to just remind everybody, it's delightful to see so many people on the call, that there are no, any question is welcome. And if you want to put it in the chat, feel free, or just, I'm happy to speak to anything that may have come up as a result of the research or related to questions that are top of mind.
Dr. Eisenberg, we had one question come in directly to me asking, when can we expect to have a cure for Alzheimer's disease?
That is such an important question. And I wish I had the crystal ball to answer that. There are ongoing efforts. And, I think that we used to think of Alzheimer's disease strictly as a neurodegenerative condition. And I think that what we're coming to understand is the relationship between these modifiable risk factors that I've been speaking about. So while we presently do not have any disease modifying therapies, nor do we have a cure, by implementing these changes, we can, number one, reduce the risk, and number two, slow things down to live well as we can with the disease. Additionally, we are building programs and services out more broadly through the state to really support families to live well. And these programs can have a terrific impact, even virtual spaces for connection through MomentiaSeattle.org, for example, or other wonderful community programs. So I wish that I could say that I had the cure available, and I don't know the answer, but I think that what we do know and what the science has really demonstrated, which is very exciting, is that 40% of the risk is modifiable over a lifespan. I also want to add one thing, which is that the genetic type of Alzheimer's disease, the early onset, autosomally dominantly transmitted Alzheimer's disease, is less than 1% of the disease. So the vast majority of us really have things we can do to target that risk. Does that? Yeah. So let's see here.
That was actually very similar.
If someone, I can read these off. Can I just read these and then I'll answer them?
That sounds great.
If someone is if someone is tested and has the gene, what are the things they could consider to stay healthy even if they're not diagnosed? That's from Andrea King. So thank you for that question. And I think I addressed it a little bit. I hadn't seen that question, but it's sort of, we were on the same page. So as I said, fewer than 1% have the autosomal dominant form. So if you are tested, I would not recommend doing an at-home test. I would recommend you have a conversation with your team and speak to a genetic counselor because this is a very complex pathway about how you would manage that information. So when people ask about those in-home kits, I have people coming in the office and saying they did the 23andMe and they may have that ApoE4 risk. And that's a very different genetic risk than the presenilin risk of presenilin 1, presenilin 2, or the amyloid precursor protein, which are the three genes that are, autosomal dominant, meaning that if you have that gene and it's 100% penetrance, you will develop the disease. But that, as I said, is fewer than 1% of all cases. So if we're talking about the late onset susceptibility risk, which is the ApoE4, that is modifiable. So, and we know that by exercising 30 minutes of cardiovascular exercise, 5 days a week, and eating a Mediterranean low salt diet, the mind diet, and by challenging the mind to learn new things, and by getting enough sleep, and all these things that I'm going to talk about at the next at our next lunch and learn in far greater depth. By implementing those changes, we can really target the risk. And in fact, there have been studies, and perhaps I'll show those at the next lunch and learn, where they looked at the mean cortical binding potential for amyloid. So meaning that they looked at that protein aggregation in the brain for people who had that ApoE4 susceptibility risk. And what they demonstrated in the study was that people who exercised consistently actually had fewer protein aggregates in the brain. So a susceptibility risk is very different, just to clarify. That is not a predetermined risk. And if people come into my office and they say that they have a family history of Alzheimer's disease in their relative in their 80s, what's likely that risk, it's not a familial risk in all likelihood, it's simply advanced age. So our genes are not our history, they're not our future. There's something called epigenetic modulation of gene expression, which is how the environment and our interaction with the environment determines that risk, how we live well. And lastly, and I think this is very important here as well, is our outlook really matters. So if we think of aging as conferring wisdom, or allowing us to have more time with our beloved family, our grandchildren, this is actually neuroprotective and is associated with a reduced risk of dementia. This was a study of over 4,000 people. So really making sure too that we are cultivating that positive mindset and not submitting to the ageism that is so pervasive in the media. Okay, so let's see here. So Pinky Herrera says, from the patients you've been treating, could you tell if the dementia is more prevalent in certain ethnic groups? And yes, absolutely. And we know that African Americans have twice the risk, and Hispanics have 1.5 times the risk of white Americans. And we know that the risk in Native Americans is also much greater. And there are a variety of reasons, including social determinants and among other reasons. And yes, and we're trying very hard through collaborative work to raise awareness around this. And we know that there's a delay in diagnosis as well in many ethnic groups, as I spoke about, and consequently then people can progress at a more rapid rate. Okay. So Jesse, thank you for that question. I think that's important to underscore again. I appreciate that. So Jesse, I don't know if I'm pronouncing your last name right, Schauver says, have you heard about, and if so, what are your thoughts about Alzheimer's dementia medication coming out of China, GV971? So that's a great question, and I haven't seen that data really to comment, and I can take a look. I think that there's aducanumab is a monoclonal antibody that is now in front of the FDA, and we should hear in 2021 about that, and there are other clinical trials ongoing. Thank you. So Ange Maya Dev asks, are there any apps or websites? Yes, that is a great question. So some of you may have known that Lumosity was actually fined for overstating their claims. Lumosity is one of these brain game training apps. What I would recommend, and I'll put it in the chat, is called Healthy Minds Program. And this is a fabulous and free program that was created by the other UW, not the Husky UW, but the Wisconsin UW. And what it is it's you can download it on your tablet or on your phone. I think that's a fantastic question. So I'm glad you raised that. And Healthy Minds program, as I said, is free, and it really focuses on the four most scientifically proven constituents of well-being. The first of which is awareness or concentration. And as we get older, many of us have diminished focus. In fact, all of us are susceptible to that. And so through these practices in this app, we have an opportunity to strengthen the neural circuitry for awareness and attention. And what we know is where attention goes, energy flows. And our brains and our minds are changing all the time, wittingly or unwittingly, meaning based on our conditioning and our environment. And so I appreciate that question. And I think that focusing your attention on how doing it, it's 5 minutes or so, it's a great application, and I would strongly encourage people to do the experiment for themselves and see how that feels to them. Okay, so Roger Chaffin says, is this presentation available for me to sit down with my family who are working at the moment and review? Yes, it is recorded. So you can absolutely do that after. Thank you. Oh yes, Marnie, you answered that, excuse me. Okay, let's see here. And then let's see, how is it that it's verified that few pneumonia vaccines seem to reduce dementia? So that's another great question. And it is, as I mentioned, it's an association study that was hot off the press in this 2020 Alzheimer's Association International Conference. And so we don't know forcibly that it's the vaccine per se, because things can be true, and they might correlate. So for example, people who get the flu or the pneumovax may have better access to healthcare more broadly, or they may be incorporating other healthy behaviors, for example. So it's also possible that it helps reduce inflammation and we have a stronger immune system, so we're more resilient. So I can imagine a number of possible hypotheses to explain this association. I did want to share it with you, however, because it's a current research observation. And whereas it may be correlational, it doesn't mean that it proves that it's protective. It looks like it's associated with protection for dementia risk, in that people who had the flu and pneumovax had lower associated risk with dementia.
We had another question come in.
So I see it. Yeah. So thank you. So Ange Maya Dev says, thank you, Marnie. I appreciate that. It just popped right in too. Can you discuss atypical signs of mild cognitive impairment, in parentheses, like difficulty getting things done, that you commonly see? Yes, I'm happy to do that. So mild cognitive impairment can present in a variety of ways. The most common way is amnestic. Amnestic means having that tip of the tongue dysnomia, having memory issues. So amnestic meaning memory. So maybe losing your keys, your phone, your pocketbook repeatedly, because everybody loses these things from time to time, your glasses. But so if it's really, so that's amnestic, memory predominant mild cognitive impairment. There are other types of mild cognitive impairment, such as executive dysfunction or multiple domain. So executive dysfunction, mild cognitive impairment might present with somebody who perhaps previously was really good at getting online and planning trips and hosting a large dinner party and making that list and executing the task with no trouble. Whereas if you have a dysexecutive or executive challenge, mild cognitive impairment, it might be a lot more arduous, or you may really just be overwhelmed and unable to do that, to make that, compare in online different costs for the airline ticket, or if you're having that dinner party, to think about what do you want to make seasonally, do any of the people have any food issues, what do you have to start with first, all these kind of complex tasks that require that you maintain attention and then you shift attention and that you prioritize and you plan and you execute and implement. That's kind of complex executive functioning. So that's another way that mild cognitive impairment could present. Um, some people have visual perceptual challenges as a presentation. Some people may have language issues as a presentation. Okay, so another question that just came in is a question about diabetes and whether diabetes causes Alzheimer's disease. And that's a really important question too, because diabetes is so common in in the population at large. And a lot of people who have diabetes are very familiar with the risk of, for example, neuropathy or nephropathy or retinopathy, meaning eye problems or kidney problems or problems in the feet, but they may not be aware of the cognitive challenges that are associated. So diabetes in and of itself, poorly controlled diabetes is associated with dementia. And some people also think of dementia or Alzheimer's disease as type 3 diabetes. So it increases the risk. And that again is that relationship between metabolic and vascular factors and Alzheimer's risk. So it can accelerate. So people can sometimes accrue that neuropathological burden and do quite well clinically, meaning that they may have the plaque entangle, the protein aggregation in their brain that I spoke of earlier, but they may not have the clinical manifestations, meaning that they're still thriving, they're still living independently in the community. So we know that if you have vascular metabolic disease, that accelerates the clinical symptoms. And what I'm referring to in terms of the research and the science is that there was an autopsy study of people who lived well into their 80s independently in the community. And what they found at autopsy, and these people had normal neuropsychological testing and they were doing well functionally. And what they found was that a third of those people who had autopsy studies, it was quite a large study, had actually the signature of Alzheimer's disease, meaning the plaque and tangle evidence of Alzheimer's disease in the brain. However, they did not have clinical manifestation of the disease. Again, underscoring the importance of really targeting these health behaviors that can impact risk. Another question that I frequently, oh, here we go, excuse me. So are there any medications that slow the progression? So this was actually, I was going to answer this in the obverse. So there aren't any current disease modifying therapies, but I spoke about diet, sleep, exercise, challenging the mind to learn new things, a good community of support, addressing depression and anxiety, staying connected, these kinds of things that really can make a difference. And then the other component of this question is that there are not medications that can modify the disease, but there are medications that can increase your risk of the disease. And so some of those are over-the-counter medications. And I'll just take a moment to mention a couple that people don't tend to think of. And for example, Benadryl is associated with an increased risk of dementia. So people don't, if want to look at those medications, the PM medications like the Tylenol PM, and not take Tylenol PM because, excuse me, taking Benadryl, of course, if you have a rash or hives is okay, but to take it every night for sleep is associated with increased risk for dementia. And so you want to come to your primary care doctor or your neurologist or come to the Center for Healthy Aging, and we would do a very thorough assessment of all your medications, including your nutraceuticals, including your over-the-counter medications, to make sure that what you're taking is safe. And we live in a country where there's direct to consumer advertising. And so it can be really confusing to know, and people are out there saying and targeting you with this one, buy this one, and this works really great. And unfortunately, there is no regulation of those claims. There's no FDA regulation of the nutraceutical industry whatsoever. It's a multi-billion-dollar industry. So, we just don't know the answer about those types of medications. Now, we do know that in the Pacific Northwest, which is quite north, people may have a vitamin D deficiency. We also know that if you take certain medications, you may not absorb adequately B12. So there are certain deficiencies of micronutrients or endocrine disturbances that may increase your risk of dementia or cause worsening of symptoms if you're living well with dementia. And so, taking vitamin D if you have a low vitamin D level or taking B12 because you have low normal B12 is appropriate. It's just that we don't know about all these other many nutraceuticals that are out there. What about melatonin? Great question from Jesse Shauver. Um, you know, that's kind of all over the map. So generally speaking, um, I think that low dose melatonin can help if you have a circadian uh, sleep dysregulation as we age. So sometimes as we age, it's harder for us to settle at night. And you could try a little bit of melatonin, but there are other approaches to help with that, like making sure that you're not on your phone and you're limiting the light exposure and you're not watching things that are upregulating and you're avoiding caffeine and those kinds of things. So melatonin, I think in low doses is okay, but there are also other approaches to help with insomnia. And it's important to acknowledge that insomnia absolutely is associated with an increased risk for dementia. And we know that when we're sleeping restfully, we clear a lot of those protein aggregates for the brain. So when we get a good night's rest or restful sleep, we really can help with flushing out those harmful substances for the brain. Okay. So, does moderate 2 to 4 drinks a week of alcohol increase risk? Another super important question. And there are answers from both sides of the spectrum. So there is some science, particularly as regards vascular tone, that um, you know less than 21 units, as I presented earlier, of wine is okay. So 2 to 4 drinks a week to me is probably less than 21 units. And so I would say that my reading of the literature right now is that is in some studies has been shown to be neuroprotective. And in the Mediterranean, in the MIND study, which was almost 5,000 people over 5 years, where they cut the risk of Alzheimer's disease almost in half, actually 53%, so it was over half. Those folks had about a glass of wine a night on average. So I'm not, caveats, of course, are if you have a history of alcoholism, there are many reasons that it's unsafe for people to drink alcohol. So I'm not saying this across the board. So if you have a history of alcoholism, or if you have liver dysfunction, or if you have a bleeding issue, or talk to your primary care provider or come to our center, or we can kind of look at that in a more granular way. But broadly speaking, looking at the science today, mild consumption of alcohol in some instances has been demonstrated, in large populations actually, has been demonstrated is associated with neuroprotection or reduced risk. We know, however, that if you drink more heavily, you increase your risk of stroke and dementia. And in fact, I will say that in early onset dementia, the single greatest association is heavy alcohol use. It's not genetic because it's less than 1%, but it's heavy alcohol use in people who present young, meaning under the age of 65. Because we know 60 is the new 30, right? But definitely it's a risk, and we know that we don't know what the exact proper dose for an individual is, and we don't know which organ that alcohol is going to affect, whether it's going to be the liver or the brain. So it's it's a cautionary. It's an intoxicant. It can harm. Okay. So this question that just came up is, how can I best help my husband who is experiencing cognitive decline, and that you're observing in him. And I would say that the first thing to do is to really talk about that with his care team and get an evaluation, at our center, at the Center for Healthy Aging, because there may be undiagnosed sleep apnea, or he might be on a medicine that's harming him, or it might be that he needs to exercise. There are things that people can do every day to impact um, health span and well-being, and it's never, as we